Okay, everyone, we stopped on this slide right here just talking about the different populations by age group across our country and the mental illnesses that they deal with and some trends that we start seeing here in terms of where we might see more mental illness cases in certain population segments versus others. So the first question we talked about in class is where do we see the biggest increases over time? And based on the data, we see that in the 18 to 25-year-old range. So we can start to make some assumptions based off that. In particular, around the times we start to see those increases. So we start to see a slight uptick starting in 2009, going into 2010, and then a slow, steady increase all the way into 2014. If we think about things that are happening in our country at that time, we have the recession. The job market is getting tougher because of the recession. So we have a lot of students or a lot of young individuals in that age range coming out of college with large amounts of education, debt, and loan. And with the tough job market, it's hard for them to find employment. So they're in this pivotal transition phase in their lives. And so that can create or set up the conditions for them to experience different types of mental and behavioral health issues. So when we start thinking about just the different aspects that are behind behavioral health in a public health sense, and if we look at it from a public health and of course an administrative perspective, there's some very significant public health issues that exist here, all of which we've kind of touched on throughout this lecture, resulting in a loss of functioning. They're not able to be functional members of society because the mental or the behavioral health issues that they're experiencing are so severe that they are just not able to function. In addition to that loss of functioning, we have some very significant healthcare issues in general, just with the biological undertones, with the imbalances that exist. How do we begin to adequately and accurately care for these different for this different and special population subsector that we see here with those suffering from behavioral health and mental health issues? And then if we take that a step further and even zone in on our particular region and look at more rural health populations, and in particular to this area, if we look across the country in the rural areas, about half of those rural counties have no practicing mental health clinic. So what do you do if you are an administrator in a very small, very rural county that's lucky to even have a hospital? How do you care for the mentally, those suffering from mental illness in your area? Now, do we really have the resources to address this? And you can probably go ahead and surmise that no, we don't, based on different conversations that we've had over the course of your time in the program. We really don't have the resources to address this as we should. Mental and behavioral health, for whatever reason, has kind of been pushed to the back burner. We've not really had a big focus on it, whether that's because we're focusing more on one sector or section of healthcare versus others. We're very uncoordinated with what's going on with mental health. We have physicians who don't speak to each other about mental health issues that are going on, so there's a lack of coordination. But if you look at it from a job perspective or an employment perspective, the mental health field is severely, severely understaffed and underserved. We do not have a lot of practitioners being trained to go into mental health and behavioral health. And that goes from your mid-level providers, even take it down to your bachelor's level employees, your mid-level providers like your nurse practitioners, your PAs, and then even all the way up to the doctoral levels. We don't have people going into practice mental health like we need to. We see this on the primary care side as well. We've talked about the anticipated shortage of primary care providers, both the doctors, physicians, and our mid-level providers. And it's even worse from a mental health perspective because we have more, less people going into mental health than what we need. And, part of that is due the increasing demands that have come out from the Affordable Care Act can put a strain on what we do already have in place when we look at the different rules and regulations that go along with that. How do we throw this extra piece of behavioral health care in there and make sure that we have the appropriate resources to start to work towards solving this issue? So as we start to look forward, what do we currently have in place right now? So we know private insurance, in terms of reimbursement, overall they've been less generous on reimbursement for mental health care in particular, though we are starting to see that trend change. A lot of insurance companies and employers have started, there's been a trend starting of, you get so many sessions for free. I think the number is about maybe six sessions for free, and then after that you have to start paying for them on your own. But 6 sessions can make a huge difference to somebody suffering from mental and behavioral health issues. Now employers, as well, like we said, they often either don't cover it or there's very poor coverage, but we're starting to see that trend change. So what we see happening is, or what we saw happening, was the introduction of the Mental Health Parity Act in 1996. Now, we talked about this in health systems, but so we'll revisit it briefly here. But the Mental Health Parity Act, if you'll remember, came in and told insurance companies, hey, you guys need to reimburse mental health providers the same as you would medical providers. So historically, what we were seeing happen is that you would pay a doctor to, check something like your blood sugar. They may get reimbursed $100 for their fee, but insurance companies would reimburse mental health providers for their services at a substantially lower rate, maybe $10. So there's no really incentive to go into mental health, and that's why we're seeing the shortage of mental health providers now, because the reimbursement from health insurance companies was so low that there was no incentive to go into mental health overall. So we thought we had the problem fixed with the MHPA Act in 96, but companies found a way around that and around those reimbursement issues. So in 2008, we had the introduction of the Mental Health Parity and Addiction Equity Act, the MHPAEA. So this built off the act in 1996, and now what we're saying is that insurance companies, you're now reimbursing equally, but now you have to provide mental health at a cost comparable to those you insure, at a cost comparable to other services. So even though you may be reimbursing equally on the provider side, on the subscriber side, you may have a $30 deductible to go to an urgent care center, but you may have a $100 deductible to go see a mental health provider. So now we're trying to equal out the deductible piece on the subscriber side to encourage people to go seek mental health services, and push them into seeking treatment if they need it. So as we move from that more into current issues that we're seeing now in terms of the Affordable Care Act and with the way healthcare policy and legislation is going, who knows what lies on the horizon. But when the Affordable Care Act came out, it basically came out and said that if insurance plans, if you want to participate in the market exchange, you have to offer some type of mental health service in what they call the basic package. But we know the reality revolves around that gaps existed because of the way states manage the expansion program. So not every state had to expand Medicaid services. They could opt out of that expansion. So states like Tennessee, South Carolina, we saw no expansion of their Medicaid programs. And now we find ourselves in a position where we have people who need mental health services, but they're not able to get it because the states didn't expand their Medicaid program. And so now these populations do not have access to that same level of care. So like we said earlier, a couple of slides ago, the provider shortage at mental health, if we thought the provider shortage on the primary care side was bad, the provider shortage on the mental health side is even worse.